apart from cirrhosis of the liver and liver diseases, another big problem for patients who have alcoholism, chronic alcoholism, is chronic pancreatitis. And chronic pancreatitis can be either due to, as in usually in alcoholics, due to repeated insults of the pancreas, but it can also be seen in non-alcoholic patients due to autoimmune problems or other underlying disorders. So the anatomy is not really important for this particular lecture, but it is good to know that the pancreas kind of nestles in behind the stomach and in the C loop of the duodenum. So remember that the duodenum makes this kind of C after it comes off of the stomach. So into the second part of the duodenum comes the ampulla of Vater, and the ampulla of Vater is just the confluence of the pancreatic duct and the common bile duct. So not much else to know there. Okay, here's our vignette. So a 54-year-old man presents to the ED complaining of severe subcostal upper abdominal pain, which radiates around his back. It started 3 hours ago, shortly after finishing a dinner of steak and French fries. He had a similar episode like this last week after eating, but was not seen because the pain went away before he could get to the hospital. He has not vomited and is not nauseous. He denies any changes in bowel movements or color, although he says he usually has loose bowel movements. Blood pressure 145/90, heart rate 100, respirations 22, temperature 98.8, saturation 93. He smokes tobacco and consumes alcohol regularly, about 6 beers during weekdays and 9 on weekends for the last 35 years. His last drink was this evening. He has no other complaints. He has no surgical history. His past medical history is significant for bipolar affective disorder type 2, which has been well controlled on lithium. He is also prescribed loperamide for daily use. Physical exam reveals a thin Caucasian male, upper abdominal tenderness, no distension, guarding, or peritoneal signs. His bowel sounds are diminished. Lungs are clear to auscultation. There's tachycardia, but a normal rhythm. What are the labs you're going to get? For most cases of acute abdominal pain, I would say pretty much all of them, you're going to get a CBC, you're going to get a CMP, which is just a basic metabolic panel plus liver enzymes. You're going to get amylase. In this case, you're going to probably get lipase too because we're concerned with pancreatitis. You'll also want to get an EKG and plain films, either the chest, the abdomen, or both. Definitely in this case, the abdomen. And what do we find? So we got a CBC that's normal. The CMP reveals an elevated ALT and AST. AST is greater than ALT. Glucose of 323, which is really high. Amylase is elevated. Lipase is elevated. The EKG shows sinus tach. Chest x-ray is unremarkable, but the abdominal x-ray shows evidence of minor pancreatic calcifications at the level of the pancreatic head. And that's really the kicker there. Just with that word, that phrase, you should know that this is chronic pancreatitis. And you probably knew that because that's what this lecture's on. Don't be sly. All right, so how do we know before the labs that this is probably chronic pancreatitis versus acute pancreatitis? Well, we don't necessarily know for sure, but there are some things that may give us hints. Definitely not the pain. The pain is similar between chronic and acute pancreatitis. It might not be as severe with chronic pancreatitis, but that's difficult to gauge because different patients will report different pains as being severe or less severe. The pain came on after eating. That can happen with acute pancreatitis too, but with alcoholics, usually the pain does not come on after eating. Now with chronic pancreatitis, the pain is going to be worsened with eating. Why? Because that activates the pancreas. In most cases, patients with chronic pancreatitis, the pain will be connected to some kind of meal, especially a fatty meal, not carrot sticks. Another thing is that he says that he usually has loose bowel movements. Remember, what does your pancreas make? It makes lipase, and lipase is responsible for breaking down fat. If you don't break down fat, fat's going to be in your stool, and the fat is going to cause both gas and it's going to cause diarrhea. So you get steatorrhea and gas. and that's going to be the loose bowel movements. So the fact that he says he usually has loose bowel movements says something is going on GI-wise, that he's not absorbing fats. Well, if he told you he had loose, oily bowel movements, I suppose. But chronic diarrhea, one of the things that you should think of is steatorrhea, i.e. chronic pancreatitis. Okay, the fact that he smokes tobacco, this smoking tobacco is an independent risk factor for chronic pancreatitis. And then, of course, consuming alcohol regularly to the degree he does, 6 to 9 beers a day for the last 35 years. This guy, if you probably asked him, or if you looked at his medical record, he's probably been in for acute pancreatitis at least once before. Also that he's thin. So patients with acute pancreatitis can run the gamut from thin to obese. Patients with chronic pancreatitis have a tendency towards thin. They don't have to be, but they have a tendency towards being thin. Why? All back to this loose bowel movement issue. What are they not absorbing? They're not absorbing fat. And remember that fat is twice as many calories as a gram of fat is twice as many calories as a gram of carbohydrates or a gram of protein. So these patients are usually malnourished. Lab-wise, CMP reveals reveals probably some alcoholic hepatitis. The AST is slightly greater than the ALT, so that points you towards an alcoholic hepatitis. The glucose is very high, and that is possibly pancreas in origin. So the glucose should never be 323, and that would be an immediate diagnosis of diabetes if you did see that. But what in the pancreas would cause you to get this high glucose? Well, having idiopathic diabetes mellitus, of course, but if you have chronic pancreatitis, you're not properly secreting insulin. And if you're not making insulin, then your glucose level is going to be higher. The amylase and lipase. This is not going to feature to the same degree as with acute pancreatitis. So remember, with acute pancreatitis, you can almost make the diagnosis based on the fact that amylase and lipase were more than 3 times the upper limit of normal. With chronic pancreatitis, that's not the case. So the amylase and lipase, usually when you have your acute pain episodes with the chronic pancreatitis, they may be elevated, but patients with chronic pancreatitis may also have normal amylase and lipase levels, or they may even have low amylase and lipase levels because the pancreas is getting burnt out. By the time it's chronic pancreatitis, its ability to secrete amylase and lipase is diminished. So even though you've got an event of pancreatitis, because this is chronic pancreatitis, the pancreas is burnt out and it's not able to secrete amylase and lipase like a healthy pancreas that becomes inflamed, acute pancreatitis. And then what's most important here, of course, is the evidence of minor pancreatic calcification at the level of the head. That's practically pathognomonic for chronic pancreatitis, and that's calcification, as we see in a lot of different chronic inflammatory diseases. So the differential for acute epigastric pain can be lots of things. Probably even more than this, but these are the things that I like to think about immediately in a patient with this kind of history. Maybe you can cross out Boerhaave syndrome because he doesn't have a history of vomiting. But these are some of the things I like to think of. You can probably cross out OBGYN issues since he's not a woman. If this were a young woman coming in with a similar history, I might add a beta HCG and a urinalysis to the initial workup. Okay, chronic pancreatitis is a chronic inflammation and destruction of the pancreatic mucosa, parenchyma, and ductal system. This is a completely different pathologic process from acute pancreatitis, but most of the time patients who have chronic pancreatitis will have a history of acute pancreatitis because what's the big risk factor for chronic pancreatitis? Alcoholism. Same big risk factor for acute pancreatitis. In the US, it's almost always due to high alcohol consumption, but I should say with chronic pancreatitis, it's due to a long history of high alcohol consumption. So this isn't just your 1 week of binge drinking for Mardi Gras. This is a patient who has been an alcoholic for a long time. About 60%, and I would say that's a conservative estimate, of chronic pancreatitis can be directly related to the alcohol. About 30% are quote-unquote idiopathic, and about 10% are secondary to autoimmune or congenital diseases or malformations. Most prominent of those, cystic fibrosis, I would say also the autoimmune pancreatitis, which can be a feature of, it can present with primary biliary cirrhosis, it can present with primary sclerosing cholangitis, it can present with Sjogren's syndrome, or it can present entirely on its own. Men tend to be affected more than women overall. However, if it's autoimmune pancreatitis, women have a dominance over men, as they do with most autoimmune diseases. Blacks tend to be affected more than whites, and I believe that is controlling for alcohol consumption. Black people have in the United States, have a per capita higher rate of alcohol consumption, but I believe that this statistic is correcting for that. All right, history. Very important to document the history and degree of the patient's alcohol habits, since that's behind most cases. Not just their habits, but how much they're consuming when they, you say, how much do you drink? Oh, 5 days a week. Well, how much are you drinking each night? A 6-pack. Well, a 6-pack of what? Is it strong beer or is it 3-2 beer? So you have to make sure when you're getting into the patient's alcohol history, details are really important. Because if a patient says that they had 2 drinks, but they were 2 little flimsy wine coolers, that's totally different than if they had 2 shots of 120 proof vodka. So important to have that documented very, very well in their history. As I mentioned, smokers are at a higher risk for pancreatitis, not higher than alcoholics, but smoking is an independent risk factor. So a drinker who smokes is even at higher risk. Also be alert for any past biliary problems as well. Symptoms. So why do patients usually come into the hospital? They come in because they don't feel good. They're in pain. And so that's the most common symptom on presentation, but it doesn't have to be the only position. Usually the pain is made better by certain positions, especially this, what I've seen, most of the patients that I've seen with chronic pancreatitis tend to prefer this specific position, and it's sort of laying on their side in the fetal position. And I'm not really sure why they do that, but I've even seen in the literature that this sort of sideways position is the most preferable for patients with pancreatitis. Patients with acute pancreatitis also tend to have that sort of doubled over position. Steatorrhea or gas may be a complaint. Usually, though, you have to elicit that. So it's important that you're getting a full GI history and symptomology. Check for physical signs of malnutrition. So you're looking for temporal wasting. You're looking for any kinds of signs of fat-soluble vitamin deficiency, A, D, E, and K. On laboratory examination, usually the glucose is going to be elevated. That's hypoinsulinemia from the chronic pancreatitis. Transaminases will also be elevated as well. That's not necessarily due to the chronic pancreatitis, but due to the fact that these patients tend to be alcoholics, and therefore they're also going to have some degree of alcoholic liver disease. They may have hypocalcemia. I'm not sure why, but my thought behind it is, well, they got to be putting their calcium has to come from somewhere where they're getting these calcifications, so maybe that's causing the hypocalcemia. Another thing, though, another cause of chronic pancreatitis is hypoparathyroidism. So I think I said that right. So patients who have high levels of parathyroid hormone, they can also develop chronic pancreatitis. Amylase and lipase are usually elevated in acute painful episodes, but they don't have to. So this is totally unlike acute pancreatitis, where if it was acute pancreatitis and we come back and see the amylase and lipase are normal, it's not acute pancreatitis. With chronic pancreatitis, the amylase and lipase do not have to be elevated, although they often are with the acute episodes. As far as radiology, you'll want to make sure that you're getting your abdominal x-ray in any patient you suspect chronic pancreatitis, because about 30% of them will develop or will demonstrate pancreatic calcification. And this is what that looks like. So when you're looking for the pancreas, usually go about 2 or 3 spinal levels up from the superior iliac crest, and that's where the pancreas is. When you see an abdominal x-ray in a normal patient, you shouldn't really be able to make out the pancreas. But if they have calcifications, you'll definitely see it. So here's calcifications here. These are widespread calcifications. You're not going to necessarily see all these calcifications in your typical patient. So this is more like what a typical patient might look like, average patient presenting in with chronic pancreatitis. These are more advanced patients. So best way to sort of look for the pancreas, look about 2 or 3 levels up from the superior iliac crest. So 1, 2, 3, up. Here's the calcifications. And the pancreas can be in variable positions. It's one of the most anatomically variable organs, so it's not going to look the same in everybody. So here's where the pancreas is. Here's another one, again about 2 to 3 levels up from the iliac crest. Right here. What do we do for chronic pancreatitis? We treat this similar to acute pancreatitis, but we don't have to as much worry about the complications. We're not as concerned about the development of sepsis and other things like that, hemorrhage. However, it can happen. It's not as in the front of our minds as with acute pancreatitis, which is much more of an emergency, much more lethal in the acute phase. So the treatment for them are going to be admission. We'll want to put them on pancreas rest, so NPO for 24 to 48 hours. Of course, we're going to be giving them IV fluids because they're not eating anything with glucose added onto that. Daily labs, analgesics for their pain. You can advance their diet as tolerated. We'll also want to give them pancreatic enzyme supplementation. There's various preparations of this. Pancreolipase is the one that I've mostly seen. There's another one called pancreazymin. And then a surgical consult. And the reason you want that surgical consult is before you discharge them, once their pain is gone, then you're going to get an ERCP or an MRCP on them to evaluate their pancreatic ducts. The reason you do that is because the surgeon is going to decide whether or not he or she wants to do a procedure. And the procedure can ameliorate future symptoms. The details of these procedures are way outside the scope for the USMLE and even for internal medicine boards. But what is important to know is that with a patient who's been newly diagnosed with chronic pancreatitis, you want to check their pancreatic ducts. And that is done by ERCP or MRCP, and then having a surgeon decide what the next step is. ERCP is the most accurate test for chronic pancreatitis. So I know step 2 often likes to throw at you, which of the following is the most accurate test in the diagnosis of this patient? Well, ERCP is the most accurate test to diagnose chronic pancreatitis because it gives you a visualization of the ducts. So that is the most accurate test. However, ERCP is falling out of favor to MRCP recently because MRCP is getting better at visualization, and ERCP has that added unwanted complication of sorry, I'm having a mind problem here, of iatrogenic acute pancreatitis. Remember, you're injecting dye, and because you're injecting that contrast, you can cause acute pancreatitis, especially in somebody who's already got a compromised pancreas. So MRCP is sort of coming into trend, but ERCP is still the gold standard. If the abdominal x-ray is unremarkable when they come in, There are other ways that you can diagnose them with chronic pancreatitis. Remember, I said only 30% of patients with chronic pancreatitis will actually show those calcifications. You can also do an abdominal CT. This is much more sensitive than X-ray. This will diagnose about 70 to 80% of patients. You'll see calcifications on the CT as well. You can also do a fecal fat test, and that will come back positive because, remember, they're not secreting lipase. So they're not secreting lipase. The fat is staying in their stool. So here's pancreatic calcifications on CT. Much easier to see here than on the abdominal X-ray. So the complications of chronic pancreatitis include pancreatic pseudocyst, which would present as upper abdominal fullness or discomfort, not though the severe pain that we see with pancreatitis. Pancreatic adenocarcinoma, iatrogenic acute pancreatitis. If they're getting that ERCP at the end, which they should be, you can cause acute pancreatitis from that. Biliary or small bowel obstruction, that can be either due to a pseudocyst or it can be due to the chronically inflamed fibrotic pancreas. So you can get obstruction of the biliary tract, which of course is going to present a lot differently from obstruction of the small bowel. You can get splenic vein thrombosis, and that's again due to the chronic inflammation. The splenic vein is intimate with the pancreas, and so if you get thrombosis of the splenic vein, that's going to cause left-sided portal hypertension. So gastric varices and splenomegaly. Diabetes mellitus is kind of almost the rule with chronic pancreatitis because they're not going to be secreting as much insulin, so they'll have higher levels of glucose. And so for most of these patients, when you discharge them, you're going to be discharging them on some kind of pancreatic enzyme. And then, of course, inevitably there's progression or worsening of the disease if they don't stop smoking and stop consuming alcohol.